From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome to JNC Cardio Connect. I'm Marcelo Di Carli, Editor-in-Chief of the Journal of Nuclear Cardiology. Today, I have the privilege to be talking to colleagues from Methodist Hospital who have published a very interesting study as a result of a Medicare survey that they conducted, which is going to have very important implications for our field. With me today is Dr. Muaz Al-Mallah, who is Director of Cardiac PET at Methodist Hospital in Houston and a professor of medicine at Cornell University, past president of the American Society of Nuclear Cardiology. Joining us is Dr. Mahmoud Al-Rifai, who was a postdoctoral fellow under Dr. Al-Mallah and now joined the faculty at Methodist Hospital. And he is an assistant professor of medicine at Cornell University. And last but not least is Dr. Ahmed Sayed, who is currently a postdoctoral fellow working with Dr. Al-Mallah at Methodist Hospital. Welcome, the three of you, and thank you again for joining our JNC Cardio Connect.
Thanks, Marcelo, for hosting us. We're excited about this JNC Connect series.
This survey piqued our interest because it provides a snapshot of the utilization trends of imaging modalities in the Medicare population. And it gives us an opportunity to reflect where's the field going. Dr. Al-Mallah, give us a little bit about a motivation for this analysis of the data and give us some context for the study.
The biggest question was that when we tried to look at coronary artery disease testing in the US, there was no reliable data that we could find. We tried to look in different buckets from industry, and obviously each data set is biased. We wanted to come up with the most objective data that we can rely on to see the trends in the mode of testing that we are using. Obviously, this is a Medicare population, but I think this would be the most objective data that we have to assess the patterns and modality utilization in assessment of coronary disease.
Ahmed, tell us the methodology that you use and help us dive into some of the results of this paper.
Of course. In this study, we retrieved Medicare Part B data from the Center for Medicaid Services, which provides information on the number of services ordered for Medicare beneficiaries in the United States. What we analyzed was how frequently different cardiac imaging modalities were ordered between 2018 to 2022 for the evaluation of coronary artery disease. The 5 modalities of interest that we wanted to study were cardiac PET, SPECT, CT, MRI, and echocardiography. The orders for each modality were identified using a unique set of CPT codes for that particular modality.
Mahmoud, walk us through the results, particularly on the utilization of imaging modalities.
I'll be happy to. So as far as the imaging modalities used to diagnose CAD, SPECT remains the most used modality by far, followed by PET, CT, MRI, and stress echocardiography. However, for those who are undergoing PET myocardial perfusion imaging, only 55% were doing concomitant PET CT, and only about 40% were doing myocardial blood flow assessment, which shows that there is a underutilization probably of myocardial blood assessment in patients undergoing PET CT. And why is myocardial blood flow assessment important? As opposed to SPECT, which only is reliant on relative perfusion imaging, myocardial blood flow shows the granularity of blood flow in each of the regions subtended by the coronary arteries. This is important to rule out obstructive CAD as a result of balanced ischemia from left main, multivessel CAD. It can also be used to uncover microvascular dysfunction, which is underdiagnosed with the current imaging modalities used. and also to assess whether or not the patient responded well to vasodilatory stress. Also, the data has shown that it has very important prognostic information.
I just want to also add that when we looked at the 2022 data, the CPT code for blood flow was introduced just 1 or 2 years before. So some centers may have been doing it, but not reporting it or not billing for it. So it would be interesting to see how that number goes beyond 2022 data as people are more comfortable doing it and reporting it. The data also gave us a sense in terms of PET versus PET CT. About 45% are done by PET CT, and still 55% are done with PET, which is showing the older install base that we have. Many of the people who are doing cardiac PET will modernize their labs and move on to adopt newer technologies that will hopefully enhance our accuracy and image quality.
When I looked at the data, what struck me was that almost 80% of the utilization was radionuclide perfusion imaging when you take SPECT and PET combined, and that PET was a rapidly growing modality, but still 6 times lower than SPECT.
This is a very important point. PET is growing, as you mentioned, and it is widely available in some areas, but not as widely available in other areas. There are PET imaging deserts in the country that do not have access, where patients have to drive maybe 500 miles to get to a PET center. There are some lucky states where it is widely available, like California, Texas, and Florida, but there are many states where they had less than 5 PET centers, even in heavily populated states.
This brings another related point in your study, which is a pool of people trained to read cardiac PET.
This is a very important challenge, and I would refer our listeners also to a group of articles that were published in JNC in January 2024, looking at barriers to enhance availability of cardiac PET in the United States and globally. And the main reason is the lack of trained readers and local champions who are able to start a lab and educate the referring physician about the utility of cardiac PET. In the US, still the bulk of nuclear readers are reading SPECT and not as much PET. And I think it's very important that we train them. Unfortunately, there are not too many training sites. I know ASNC is doing a lot of PET workshops, training people on the job, providing them with support. But I think we need to do more, because once we have these local champions, they will go to these PET deserts and start making PET more available and accessible for our patients, and for appropriate utilization of cardiac PET when needed for these clinical indications as has been outlined by the guidelines.
One of the takeaways for me from the paper is that despite all the criticism and bad press, most of the referring providers are still using radionuclide imaging to assess patients with coronary disease, at least in the Medicare population. What is your perception of where's the field going with SPECT and PET, and how is this going to evolve?
I completely agree with you, Dr. DiCarli. SPECT is still the predominantly used modality to assess obstructive CAD, at least in the Medicare population. So if that's a modality that's being used, I think the onus is on us to modernize our labs and use the latest generation scanners. Stress-only imaging as a default, prone imaging, and SPECT CT. I think the data from our paper nicely shows that while SPECT is still the most widely used modality, its use over the years has actually decreased, and the use in PET and CT has actually increased over the years. We're hoping that more people go into this field, become PET champions, and open up these PET centers in their areas to increase expertise. And I think the recent approval of Flurpiridaz by the FDA will expand the use of cardiac PET over the next few years.
And Moaz, do you see other priorities in terms of research? What other evidence do we need to collect to advance or to establish even more the role of PET in coronary disease?
I think we need to focus on also generating the evidence of comparative effectiveness. Cost effectiveness also is very important, and identifying the population where PET is a must rather than an option. I think there are some patient populations where PET appears to be, to me, the only option. I think we need to solidify that. For example, patients with prior heart transplant, morbidly obese patients with extremely elevated coronary artery calcium score. We need to study these populations and provide evidence that PET is not only the only choice, but it provides a very helpful diagnostic as well as prognostic information to help us manage these patients. I think this is a very important piece of evidence that we need to provide to guideline writers, but also to third-party payers so that they enhance the appropriate utilization of cardiac PET. Obviously, there is room for other imaging modalities where they become more appropriate, but I think for PET, we need to identify the patient populations where PET is a must or necessity for that population.
All right. So I think this was a fantastic conversation. I thank you again for submitting your work to the Journal of Nuclear Cardiology. This data makes an objective and compelling case for the priorities that should be taken in the field. It also provides a snapshot of where the field is going for our industry partners. I thank the three of you so very much for the time you spent with me today, and congratulations again on a wonderful paper.
Thanks for having us, and we're really proud that this paper was well received by the editorial team and also hopefully by the JNC readership.